Hello, everybody, and welcome back to Project M.O.V.E. Thank you for joining us. I'm here with Dr. Josh Weidman, myself, Matt Tremarkey, and today we're going to kind of talk about low back pain. I'm sure you've all kind of been there where we've maybe had to tweak something in our back, and we kind of felt this kind of like sharp pain, and then we were kind of for like a few days kind of limited in range of motion. Maybe you've been told you have a bulging or herniated disc. Well, today we're going to go through all of that. We're going to start with a little bit about basic anatomy, kind of talk you through a little bit about the spine and how it works, and then kind of take a deeper dive into there.
Yeah, so I mean, 80% of the population is going to have back pain at some point, and it's the reason why most people miss work. So yeah, it's a growing problem, and it's not something that's really getting better. So we wanna kind of tackle, maybe some ins and outs that aren't always talked about, and see if we can't help along the way.
Yeah. Okay, so let's maybe start with a little bit of basic anatomy. We're not going to go too into the weeds here, but the spine's going to be a little bit different than any other joints in our body. The spine, well, for one, is made up of several joints. Most people think it's kind of just this one thing, but it's literally just one joint sitting upon another joint, sitting upon another joint.
Right.
And what really kind of sets it different than every other joint, like shoulder, hip, knee, elbow, is its primary function. So its primary function is going to be linear based first. It needs to be able to flex and extend, so kind of move north and south,
right,
before you can have any sort of rotation or lateral flexion.
Correct. So the facet joints, which are the joints kind of in the back part of the spine, they're oriented in different angles depending on where they are in the spine. And so their primary kind of path of motion is that flexion extension. And so if you think of rotation is coupled motion, where we're going to get a little bit of flexion on one side and extension on the other, and that's going to kind of create that rotation. And then the side bending is, again, kind of a combination of the two. So whereas a shoulder joint, a hip joint, rotation is going to be primary, the spine, that flexion extension, is primary. So it makes us take a little bit of a different approach whenever we're talking spine rather than hips or shoulders.
Yeah, because the spine, if we look at the deepest anatomy, the deepest movers,
Correct,
musculature, we're looking at flexion extension, whereas every other joint we're looking at rotational base.
Yeah, the musculature around the shoulder joint, the deepest muscles, they're providing that rotational kind of movement, whereas at the spine it's going to be that flexion extension movement.
Yeah. Okay, so yeah, kind of keeping on this anatomy. So we have each vertebra sitting on top of each other. Then we have our disc kind of sitting in between.
Right.
And we got the facet joints that are kind of just go right along the side. And then we kind of essentially have nerves that are kind of coming out in between that space between the spine.
Correct. Yep. So the discs, that's obviously how we we have space between the joints, right? And so if you think of, not to go too deep, but like we think of the spine as this column, right? But imagine it's really like the joints are floating within the tissues. So instead of it just being like a column, it's the bones are floating within the connective tissue and all that. So it's a little bit of a different way of thinking about it, rather than just like a rod or a pole or something along those lines.
Yeah, because it's actually like the only part of our body where we don't have any sort of rigid skeletal system, like a solid bone that runs the span. It's just a whole bunch of independent segments that are kind of like that free floating. So it seems like we're a lot more vulnerable along our spine, just because we're sitting in free space and there's just joint upon joint sitting on top of each other.
Right, and that's where we need basically the symphony of the entire body working well together to provide that support. Whereas with a hip joint or a shoulder joint, we have a little bit more integrity just by the structure of the joint, where the structure of the spine is a little bit, it's not necessarily more vulnerable, but it is a little less inherently less stable.
Well, I mean, I think it is. I mean, just because when we're moving the rest of our body, if we don't have a full range of motion or we have limited range of motion, uh, we're going to compensate in other areas.
Sure.
And if we don't have 180, so let's walk you through examples. So let's just kind of take something I kind of see all the time in the training space is people who lack full overhead mobility and then also limited hip mobility, especially internal hip rotation. So if we don't have 180 degrees of shoulder flexion, whenever we try to go put something overhead, in order to get 180 degrees, we're going to fake it by moving into some sort of extension in the back.
Right.
More than likely, probably lumbar extension. So yeah, now whenever we go to put something overhead, now we're not only doing a shoulder exercise, but we're also doing a back exercise. So now we're constantly training the spine to kind of go into extension, usually in this kind of lumbar area.
Yeah, we're almost going into that excessive arch of that low back.
Yeah, so let's compound this, and let's now also throw in someone who we see all the time with limited hip mobility and internal rotation. So whenever you have limited internal hip rotation, if you're trying to squat down to depth or move into above, like 90 degrees in hip flexion, actually really 60 degrees of hip flexion, we're going to compensate in lumbar flexion.
Yeah, you're not going to get much, but yeah.
So let's just take somebody who has got limited shoulder flexion and limited internal hip rotation. So now we're seeing these compensations in that lumbar spine of just being essentially creating more hypermobility in that lumbar spine, whether it's going into more excessive extension and flexion and going back and forth. So now as we're moving through exercises, we're essentially not necessarily training the muscle group, the tissue that we're wanting to. We're now also training our low back, and we're asking our low back to essentially do something it wasn't necessarily meant to do.
Correct. Yeah, so imagine if you're stuck here and the only way to get all the way up is to kind of bend through the low back. So this is where the whole core exercise can be like a challenge, because it doesn't matter how much core exercise or stiffening of the core that you try to do. If your goal is to get your arm over your head, you're always going to give up your core because you don't have the shoulder to be able to do it.
Yeah, and yeah, I don't care. Like if you're, especially like Olympic lifting, if you're trying to put something overhead like a jerk or a snatch, in order to secure that weight overhead, you're going to have to be perpendicular to the ground. You're going to have your arm angle at 180 degrees. So if you don't have that by its like that shoulder range of motion by itself, no matter bracing, no weight belt is going to help you or prevent you from moving and compensating in your spine.
Right.
Okay, so we painted this picture, somebody who's got limited shoulder mobility, limited hip mobility, and now we see increased movement in the spine. And now we're kind of opening ourselves up for more injury because, as we've said in prior podcasts, what is injury? It's whenever the load exceeds the capacity of the tissue.
Correct.
The tissue is going to injure.
Yep.
And now, since we can't move properly in the shoulder or in the hip or some combination of both, now we're asking our back to do something that it's not normally supposed to do. So the likelihood of injury is now increasing because you're just going to be going into these micro movements all the time, and it might not happen tomorrow, it might not happen the next day, but eventually down the road, that tissue might yield to the load that you're putting through it.
Yeah, so there's a couple of points here. So the middle of the disc is the nucleus, and then you have the annulus, which is the tougher component around. And so there are two different types of material. So the annulus on the outside is this dense kind of cartilage type material, whereas the middle is a little bit more, I mean, everyone refers to it as like the jelly donut, but it's not that like watery. It's a little bit more like toothpaste, if you will, like a gel. So Under normal circumstances, the compression of gravity or the compression, um, whenever the annulus is perfectly intact, it's this unit where it's basically non-compressible, and so it distributes the load very well. But now you take the scenario that you just explained very well of not having shoulder mobility, not having hip mobility. So now we're forcing the spine to go into excessive flexion extension. And we're going to get into like hinge points and that here in a second. But if we're moving excessively through the spine, imagine over time that non-compressible like inner material, it starts to almost delaminate those annular fibers. So it's pushing its way into nooks and crannies. And so over time, it's opening up spaces. And this is where we start to get into terms like disc bulges, disc herniations. And so we can start to see this annular breakdown because the nucleus is starting to kind of find the weak zones. Um, think of it as like a paperclip. You keep bending a paperclip back and forth, eventually there's going to be a bit of breakdown. So it's similar to that.
What about like the tire analogy?
Yeah, so like the radial tire. So
Yes.
imagine, you've got a 10-ply tire versus a 6-ply tire. The 10-ply tire is going to be denser, right? And so the cervical spine is going to have less layers than, say, the lumbar spine. But at the same time, there's potential for delamination in either scenario.
So maybe correct me if I'm wrong. So okay, so we have like a radial tire, and the more rigid portion of the tire is going to be that outside tread portion.
Correct. Yeah.
Whereas in the middle, it's going to be a little bit more flexible, more room to give.
Mm-hmm.
And by consistently asking the spine to move when it's not really meant to move, in these cases of limited mobility, we're now essentially creating uneven wear pattern on the tread, and then now essentially you're wearing it down, and then now at some point where that weird tread pattern is on the side, you're essentially you're more likely to have like essentially a blowout kind of in that area where
Correct.
The tread is worn down.
Yeah, and just as a clarification, so the body is not a machine, and so whenever we talk about breakdown or wear, it's not in the true like mechanical sense. Think of it as the forces going through the tissue exceed the capacity of the body to like self-repair. Yeah. And so the ability for energy to be funneled into that tissue, because collagen fibers take time to remodel, bone takes time to remodel because there's a poor blood supply. So if we're constantly funneling force into those tissues and we don't give it adequate time to heal, then over time it will lead to this mechanical failure at some point.
Okay, so before we get into bulge and kind of moving down the line as far as severity in the back, let's kind of talk about this where we kind of like we feel this tweak in the back, where we kind of have like a buckle, so to speak.
Correct. Yeah. So very common is the mid-thoracic spine, because of the ribs and the other structures surrounding the thoracic spine. This is going to probably be a bit stiff on most people, especially if we're at a desk. So the low back, or kind of this right at the base of where the thoracic spine meets the lumbar spine, that area is going to be the area where we see maybe excessive motion. And so if this area doesn't move well and the lower spine doesn't move as well, we're going to see kind of right in these zones where there's excessive movement. And so where that excessive motion happens, that's where we see a buckle occur. And so Dr. Stuart McGill, he did some interesting research where he had powerlifters under fluoroscopy. So it's basically like a motion x-ray. And so he had them in a back squat, and he had them, slowly lower, and he actually, under the fluoroscopy, saw like where the buckle occurred. And so it was basically under the x-ray, he saw the disc herniation happen because it was under such load. So these buckles occur where all the force gets kind of funneled into.
So we kind of read it. So the idea is that our spine, we've got multiple vertebrae stacked on top of each other. We should, whenever we go into kind of flexion, extension, or any sort of movement, we actually see kind of like an even distribution of kind of movement across the entire spine. And if we're kind of essentially stuck in one zone, usually kind of that thoracic area, now instead of that load being kind of distributed like evenly across each, like in between each vertebrae where the movement happens, it now kind of gets funneled into one spot, and we get that essentially all that load going into essentially one joint or one space between the vertebrae.
Yeah, so imagine if each vertebra is supposed to have a few degrees of motion, and just imagine the last 3 or 4 segments aren't moving much at all, and the upper aren't moving much at all. You're trying to put 15 degrees of range of motion through a segment that's only supposed to move 3 or 4. And so if you put 15 degrees where it's only supposed to move 3, like something's going to happen. So that's kind of the nuts and bolts of it.
Yeah, so got the buckle where not necessarily any lot more long-term or maybe more acute short-term, I guess, damage, but almost like a warning sign as far as, hey, we might be compromised in our spine. We're not actually able to move evenly throughout. So let's say we kind of keep our normal routine, we keep kind of working through everything. Kind of next up down the order would be like maybe a disc bulge.
Right. So the disc bulge. So the disc bulge is something that we can see as a normal part of aging. So the disc, those annular fibers on the outside, they're actually more tension components. And so as we lose tension over time, we can actually start to see a little bit of that bulging just because of loss of like vertical tension. We can also see that as part of that delamination process. So as that nucleus starts to migrate and we lose some of that tension because of maybe some inadequate force distribution, that's another way of loss of tension. And so a bulge, I'm not going to say is normal, but a bulge doesn't necessarily mean that there's pain. It doesn't necessarily mean that there's a problem yet. It just means that the integrity is maybe starting to dwindle a little bit.
But it can cause pain.
It can, but it's sometimes a false positive whenever we see an MRI. So,
and that's maybe we also about like age also is important in this factor when it comes to bulging disc, because as we get older, we're slowly losing that space, and like you said, it kind of naturally bulges. But if we're under a certain age, bulging is going to be, I guess, more of a warning sign.
Correct.
Than if we were later.
Yeah. So,
older.
As a rule of thumb, you can use kind of that 55-year mark. So if you're under 55 years old, the likelihood that it's disc related is much higher. And then above the age of 55, we haven't talked about this yet, but it's more of stenosis, which that's basically a loss of space. And that's for a variety of reasons that we can talk about in a second.
Yeah. Okay, so bulge essentially just kind of pushing on those annular fibers and kind of like expanding into a space we don't necessarily kind of want to go, and kind of really kind of almost bursting at the seams, but it's not quite a herniation.
Yeah, it's leading to a potential vulnerable, tissue. Just as a clarification too. So basically, however old you are, there's about that percentage of that you're going to see a disc bulge on an MRI. So if you're 30, there's roughly a 30% chance that you'll see a disc bulge on an MRI. If you're 50, like, so as you get older, the percentage is much higher. But again, over time, we do see a loss of tension. So the bulge happens. Again, it could be because of that delamination effect, but it also could just be from a loss of tension because of age-related changes.
Yeah. Okay, so let's continue down this path of, working out and compensating in our low back or
Right.
our back, and we're kind of maybe keep moving through discomfort and not really treating like the actual issue, the real issue. And anyways, yeah. So what's next down the order as far as in the injury spectrum?
Yeah, so if the disc bulge goes unchecked and you don't really address some of these other factors, this is where we're going to start to kind of go into potential herniation. And if we don't herniate, there's kind of like a delineation. So we might see the facet joints get overloaded as well. So it's kind of we could go in one direction or another, because so a lot of technique, people are going to, coach you into maybe arching your low back, right? And so what they're doing is they see you buckle into flexion maybe at the bottom of a squat. So rather than trying to fix the hips, just lock yourself into the arch position. And so what we see is this crunching of the facet joints. And so we can actually see facet joint irritation, or even facet joint where we actually start to see like bony changes because of the impaction of where we're just constantly grinding into those joints. So in an effort to like save so I should back up. So the mechanism of disc herniation typically occurs through lumbar flexion coupled with rotation.
Yes.
Whenever they've done laboratory models, either repeated flexion kind of motions or flexion plus rotation is where we start to see the breakdown occur. So if you're constantly going into what's kind of called that butt wink at the bottom of a squat,
Yep.
so you're constantly kind of folding into flexion, and we can talk about that maybe as an aside, but if that's excessive, that's going to lead you down that delamination kind of pathway.
And then you couple that with load, so heavy back squats. Now you're just squishing the heck out of that anterior portion of the disc.
Actually, it's going to be the posterior.
Posterior, yes.
So you're and here's the thing. So the coaches are going to tell you like arch. So you're going to start in a bit more extension, and then the goal is to hold that. Well, eventually, whenever you get to below a certain level, with all the weight, you have to flex if you don't have the range of motion. And so no matter how hard you try to arch, you go into that flexion. So now it's excessive, end range extension followed by end range flexion. That's the recipe for herniation over time. And then you could even have both happening at the same time. Facet irritation from excessive arching, and then with the load, you could start to delaminate and then lead to that herniation as well.
Yeah. All right. So, yeah. Anything past kind of herniation?
So there's multiple, so the bulge that turns into herniation, and then there's what's called sequestration. So the nuclear component, it kind of blows through the ligaments. It's now in either the lateral recess or the foramen where the nerve root exits, or it can be more central where the spinal canal is where the nerve roots kind of come down. So it could be more central or it could be a little bit more lateral, but that disc fragment can basically sequester, it can come off, it can break away. And so it can be kind of floating around in that space. Interestingly enough, the more severe, typically we see more severe pain acutely, but we actually see better results long term. So we see this really extreme immune response, but the immune system can actually break it down and get rid of it. Whereas if the fragment is kind of holding on and it hasn't broken free, it can be a source of constant irritation. And then taking a step back, that person who has started that delamination process. So imagine they've now opened up avenues and canals within the disc itself. And so just imagine if your training intensity starts to ramp up a little bit and your form is maybe a little bit compromised, you can start to drive that nuclear material into those areas of concern. You can have that buckle occur. You can have a flare up. You can have 2 or 3 weeks of severe pain. You can calm it down. You can do maybe some rehab stuff and it can be better. And then you might have 6 months, you might have 2 years of pain-free before the cycle starts to repeat itself. And so you might go through multiple episodes of this kind of reoccurring back pain before eventually the disc material actually explodes into full herniation. So it might not be this catastrophic failure of the disc, but it might be this chronic acute irritation depending on training loads or depending on the intensity of the activity that you're.
Yeah, and something I want to say. So we've got a saying. Sometimes it's the victims who cry out. It's not the criminals. So a lot of times with low back pain, sometimes we might actually be getting this referred pain elsewhere, and because of the spine and the nerve system, the way everything comes off of it, we actually might have more early warning signs elsewhere.
Sure.
Of an actual issue that's kind of going on in the spine. The spine is actually the victim, but because we have limited, hip rotation and internal hip rotation, that might be the actual root cause of why now your back has to overwork. But it may be even manifesting not in the actual hip, but it may be like a sciatic nerve issue that a lot of people think they have a sciatic issue. But we have this referred pain going down the leg. Is there any let's maybe kind of talk about some this referred pain elsewhere as an actual a problem of or a warning sign in the spine?
Yeah, so there's research to suggest, or it's proven that 71% of hip pain is actually coming from the lumbar spine. So you might not even present with lumbar pain or back pain, but you might come in and say, oh man, my hip really hurts, or whenever I get to the bottom of my squat, I feel hip pain. And we can do some tests that rule out hip versus spine. And if we do some spine exercises or spine things, and all of a sudden that hip starts to feel better, we're very confident that the spine is driving that hip related pain. Same thing with the shoulder. I think it's a little less. It's a little bit closer to 56% of shoulder pain is coming from the neck. So we can kind of see the spine is obviously central, and then if there's a central disturbance, it can lead to peripheral problems.
Yeah.
So it's definitely something that I always say, rule out the spine first. You might come in with a carpal tunnel or a wrist injury, but I want to make sure the neck is not driving. And then you might have a double whammy, whereas you might have a wrist issue because of poor, range of motion, but you might also have a neck issue and they might just be culminating all together, you know.
I mean, yeah, I think that it makes sense. We want to kind of start with essentially the deepest, most central stuff, and kind of work our way outwards as far as.
Preferred, yes.
Um, okay, yeah, let's maybe kind of now kind of talk a little bit about maybe this. Yeah, I guess maybe how do we go about kind of like diagnosing these issues, and then maybe then going into kind of the treatment portion.
Well, before we do that, I want to like, so I know we're going to talk about this a little bit more later, but we have this like chronic, acute kind of like on top of each other, which can start to lead to like this nervous system's heightened like sensitivity, right?
Yes, yes,
And
yes, yes,
so
yes.
a lot of times, you know, the poor mechanics will be driving the acute irritation, and then we'll have this maybe, you know, it might subside for a little bit. And so we might think that we've had this back pain for 6 months or whatever, but it's been multiple acute like reoccurrences, if you will. And so over time, if we really don't address that deeper, you know, issue, this is where the nervous system says, I'm tired of, you know, so it starts to then become sensitized. So almost everything hurts. And so then we can start to have this fear of movement, or where we're a little uneasy, we're worried that, you know, if I squat, I might have back pain or these. So we then start to almost like deviate or change our behavior based on the fear of potential, you know, pain, that sort of thing.
Yeah, it's kind of like a self fulfilling destiny, like where you're like you've had a bad experience with back pain, and then now things just kind of almost become a little psychosomatic, and where you're like things just almost just it's like a negative feedback. It just increases the likelihood of experiencing low back pain.
Yeah, and so this is where, and again, we're going to talk about more surgeries at the end, but this is where we see the potential for failed back surgery, because someone might come in with this chronic, ongoing, you know, back complaint, but we never really address those deeper issues. And so they might have surgery because they had an MRI and the MRI showed a disc bulge or whatever. They quote unquote go in and fix that, but they never really addressed how they move or the biomechanics. And so those faulty mechanics or the aggravating factors are still there. They go back into their loading patterns, and they wind up having basically the same pain, even though they quote unquote fix the problem with surgery. And so we see, you know, upwards of like 40, and depending on the research you look at, it could be even higher than that, of where, you know, people, they go in for surgery and they still have pain afterwards. And it's like, they never really dug into the deeper why.
Yeah, I think that's slowly becoming more, I guess, widely accepted. It's like the last thing back surgery is a serious deal, and we want to kind of avoid it at all costs, because usually one kind of leads to another, and it just kind of compounds, and you never end up treating the underlying issue at hand,
Right.
and it just kind of amplifies from there.
Yeah, and I think this is where we're now going to talk about, you know, the assessment and that sort of thing. I think I think it needs to be said, like, we can get locked into like the low back protocol, and it's like the person in front of us, they might be presenting with back pain that the previous person presented with, but their biomechanics and their movement history are going to be completely different. So we can't just use a blanket approach where everyone gets the low back protocol or the low back exercise. Like, we've got to tailor the approach to their specific needs. And I think that that's where the industry has maybe gone astray, that we're so enamored by, you know, algorithms and trying to kind of like streamline things, that I think the individual starts to suffer, because we're not able to truly address their individual issues, where it's like, okay, we're trying to overgeneralize, oh well, this worked for the majority of people, it should work. But it's not always the
Yeah, I
case.
think that's like whether from a therapy standpoint or from like a fitness influencer standpoint, what works for somebody works for them because they've developed ability and movement patterns that work well for them. So what works for them
Hmm.
might not necessarily work for you because you've lived a completely different life and now our body's adapted to that. So finding a therapist that takes into account like a full spectrum understanding of the way you move and is able to kind of piece the puzzle together of why you're experiencing pain where you are, and not just giving you some off the shelf kind of cookie cutter exercise to treat your pain. Like if you've got some sort of
Correct.
rotator cuff issue, I mean, not just figuring out why you have it and which position you need internal rotation instead of just giving you some standard banded internal rotation exercise.
Yeah, and I think that this is where the movement assessment, then coupled with their fitness history, their activity history, their sport, because we might see something on the table with a particular range of motion, whatever it may be. But if we know, like, just say, you sent me a patient and you're like, he's really struggling with this, like the snatch or something, or then he's also a baseball player and he's unable to, pull the ball and he's always been a pull. Like now we can start to, okay, we're seeing a breakdown in technique on the field. We're seeing performance problems in the gym, and then we're also seeing range of motion or tissue problems in the clinic. It's like, how do we now blend that all together and create basically a meaningful story that the patient can now understand why all this is happening? Because their ultimate goal is, I'm not hitting the ball as hard as I want to, or I'm not getting the hits that I used to. And then you're seeing performance drops in the gym, and then I'm seeing stuff on the table or in the clinic. So it's like, how do we blend this all together and come up with this comprehensive plan where it's not just this myopic, oh well, this is what we see in the clinic, this is what you see in the gym, this is what we see on the field. It's got to all be working together.
Yeah, I think movement history or exercise history is so important just because yeah, like you give me a hockey player and you ask them to, squat or pedal, like I already know their internal hip rotation is going to be compromised just for the years that they've been playing hockey. So, yeah, our anatomy, we are what we repeatedly do, and our
Mm-hmm.
anatomy is actually going to show a representation of that. So, having the movement history is definitely, I guess, a very important factor into treating the patient because what you've done for so long, your body's just going to end up going back to doing that same thing over and over again. So we really do have to piece everything together and figure out kind of what the root issue is.
Yeah, and I think that from the rehab standpoint, I think a lot of times we can find a workaround, and whenever we find a workaround that allows them to maybe go back to what they're doing prematurely, sometimes that can give us a false sense of security. And I'm not saying that that can't be part of the solution, but I also think that um, working in parallel, where it's like, okay, we might use the workaround as part of the short term solution, but we need to be working on the long term dysfunction of restoring movement to certain areas, um, so that we don't fall into these patterns. Because that's what we see. We see where someone has a low back episode, they do their rehab, they start to feel better, they start to go back to the gym, they start loading again, but as soon as the load kind of gets to this certain point, they start to feel vulnerable and they start to then move differently. And it's like, well, was the rehab just kind of providing that workaround and giving them a solution, but not really the deep reason of why they were um, there in the first place, or are we addressing some of those weak links and kind of building capacity and movement efficiency kind of all at the same time? So I think that we can jump ahead almost too easily because there's a lot of things that we can do to kind of short circuit the system.
Yeah.
But I don't think that that's in the best long-term interest.
Okay, so let's maybe we'll go back to the example we can use. Somebody who's got limited shoulder and hip mobility, and we'll say experiencing low back pain.
Right.
Let's kind of maybe walk you through kind of as far as what you're going to kind of like check first.
Yeah, so the first thing is what's their pain trigger. So the majority of the time, forward bending or spinal flexion is going to be where we see the pain trigger. So flexion intolerance. It can be extension, but a lot of times extension might feel stuck. It might feel limited, but it doesn't necessarily cause that zing or that pain that they came in with. Sometimes rotation can be an issue. A lot of times rotation, again, just feels stuck. It feels limited. It doesn't necessarily give them that zing. But if flexion is the painful movement, interestingly enough, a lot of times doing repeated extension movements can actually become a bit therapeutic in the short term. Is it fixing the problem? No, but it can give us an opportunity to calm things down a bit, to then allow us to work on some of these movements that might be a little bit limited. So it kind of originated in the PT world, but it's MDT or McKinsey therapy, and it's basically finding the direction of preference. So it doesn't matter. A lot of times it winds up being extension, but it could be a combination of some different movements. So if we wind up doing that direction of preference, if we come back to that painful movement, a lot of times that sensitivity is way less. Okay. And so that's kind of a diagnostic of, okay, we found the trigger, we found kind of that direction of preference. If we do a bunch of that directional preference, and this is just one approach, we could do maybe some spinal stability type things where we're working on some core stiffness, or we're working on improving the ability to create intra-abdominal pressure through breathing. Like there's a lot of things. I don't know what's going to work until I try it. So giving a blanket statement is difficult. It just depends on the person in front of me.
But yeah, like usually allowing somebody to get out of pain will then allow you to then really get you. It'll give that person more capacity to then now train the underlying cause of the issue.
Yeah. So in the beginning.
But I think definitely making sure that's well communicated to the client is very important. It's probably not done enough. So people will think, I've gotten out of some back pain, and they just kind of jump right back to what they're doing. It has to be, I think, really well explained that this is a really short-term fix. This is just going to help alleviate some of that pain. So now that we can really kind of tackle the issue at hand.
Yeah, I was reading something this morning, and it basically was saying that to truly create it should be a 4-month plan. Like you need to dedicate 4 months to, so the quick, I got out of pain in a couple of weeks or whatever, that's great. But if we don't build the capacity on the back end, you're just going to kind of be repeating the cycle again. So it's definitely worth mentioning that flares are normal, even though we might find a pretty quick reduction in symptoms within the first couple of visits. There's a likelihood that a flare might happen. That's normal. That's to be expected, and it's something that we have to work through. But it doesn't mean that you've regressed. It doesn't mean that you're right back to where you started, and it doesn't mean that you've re-injured yourself. Um, it just means that you might have felt really good, and you started doing, a little bit more like, oh, I went out and, I haven't, jogged, and I went out and I did a 3 mile jog. Well, if you haven't done that in a couple of weeks and you go right back to jogging 3 miles, you probably are going to be a little irritated just because your capacity has dropped off a little bit. So the goal is to slowly start to build that up, and you might have to kind of work through some of those flare-ups, but it doesn't mean that you're starting from square one again.
Yeah. Okay. Maybe walk me through where does this we talked about the other day. This bottom up, top down approach kind of come into play.
Yeah, so the bottom up would be basically the biology. Top down is basically brain and neurology. So um, they really work hand in hand. But depending on the person, someone might be, even though there might be mechanical issues, their fear avoidant behavior might be the dominating um, process. And so by giving them reassurance and providing them with maybe some safe movements that they expected to hurt but don't hurt. So if we can modify the squat to where they came in and squatting kills their back, but we were able to maybe do a box squat or maybe do a split squat or something that's completely different, but still is working a similar pattern, then they might be like, oh wow, I would have expected that to hurt. So we didn't really change the tissue, we just changed how they thought about it. And so we're kind of using that top down approach to kind of decrease the fear a little bit. But then at the same time, we can use a little bit more of that mechanical approach and be like, okay, well, maybe you have a little bit of valgus collapse where the knee's kind of coming in a little bit in your squat, and maybe that's loading the hip a little weird, or maybe then you're kind of going into that buckle. So we can do some changes of the actual biomechanics, and we can see, okay, well, we took a video, or we might use some 3D motion capture. We can see you're actually moving better, and then that leads to more confidence as well. So it's like we're kind of using multiple strategies to kind of create this, reassurance to be able to reactivate you back into those potential fearful activities.
Yeah, because I think a lot, especially with back pain, like, and I've had clients and definitely experience this. It's like that fear component is definitely a serious thing. So giving them some safe exercises and safe ranges of motion where they don't feel the pain, I think goes a long way. And then especially then allowing to then go from that bottom up approach, and then really kind of building the capacities of the tissue to, I guess, create change and improve health.
Yeah, and so, if you're constantly like jamming into pain, the body will actually upregulate like the pain receptors, which then decreases the threshold. So, sometimes pain, like this is an interesting kind of talking point, because there's some people who are like, oh, we don't want it to be painful because we're trying to like decrease that threat perception. And then there's some evidence to say that it can be slightly painful. We don't want it to be excessively painful, but a little discomfort is actually okay. And so the point is, if we're jamming into discomfort, we can actually upregulate those pain receptors, which decreases the threshold. So the threshold might have started up here, now it's down here. So little bitty things might start to become super painful. and we don't want that to happen. But at the same time, if we're completely trying to avoid pain, that might really put us in this narrow box and we stop doing the things that we enjoy. So the goal is maintaining activities that we enjoy as much as possible. So if we have to modify in the short term, the goal is always to like work back to those activities that we're striving to get back to.
Yeah, I think like just communication with your clients is very important. Just because there's some clients who will freak out at the slightest bit of pain, and like it's going to cause that upregulation and increase sensitivity. Whereas there's some people who can just ignore pain and just keep almost work through pain to their detriment.
And both can be a challenge.
Yeah, so you kind of have to. It really is going to come to the therapist to kind of be able to kind of have that rapport and understanding of meeting your client where they're at to really be able to kind of help them.
Yeah, and that's where finding activities that are basically you could think of the hardest thing they do well. So if it's too easy, it's basically like the brain isn't going to care. And if it's too difficult, it's going to create apathy. They're not going to care either because it's like, I can't do it. So if we can find that edge of their capability, that challenge, then we can start to create almost like graded exposure. So it's like we want them to be challenged. We don't want it to be too easy, but we don't want it to be too hard either. And so I think in a previous episode, we talked about that flow state. And that flow state is kind of where there's that perfect amount of discomfort or challenge, but it's not too much, not too little. It's that Goldilocks, finding that sweet spot where we can create that positive adaptation without overloading the system and creating that negative feedback.
Yeah. Okay, so we've kind of been going through like more rehabilitation, and I don't want to quite get into surgery yet, but how do we kind of know if we're kind of heading into that surgery direction? So we've gone through like a long course therapeutic treatment plan.
Right.
What's the next step? Is it going to be like some sort of injections, or let's talk
Well,
about.
I think before we go to injections, I definitely think that we can take a little bit of almost like a functional medicine approach, where we're kind of anti-inflammatory style diet.
Mm-hmm.
So we would want to look at hydration status, sleep status, quality of food, and really dial that in. So if you're working out and you're not getting good sleep and you're not eating great, and we're basically seeing this, like, we're making progress, we're improving, joint range of motion on the table, we're seeing some improvements in the gym, but you keep telling me, but it still hurts, or it's like, okay, well, we need to clean up some of these dietary things. And I'm not saying that this is going to like miraculous, but it is interesting how there are feedback loops from the irritation of the gut and joint inflammation and those types of things. So dialing in your sleep, dialing in your nutrition would definitely be kind of the first line of defense. We potentially could even get into maybe some supplementation, depending on the case. And if those are still not really giving us what we're after, then we would start to look into possibly an injection. And this would be mostly like a corticosteroid, where we're really trying to kind of calm down the inflammation around either the nerve root, if we're talking about an aggravated disc. We could do the facet joints as well, depending on, but that would be, and then we potentially could also do like a Medrol dose pack, which is more of an oral steroid. It's going to be more, systemic. So depending on the case, we might choose one over the other. A lot of times, even though the injection is a little bit more invasive, because it's a little bit more focal, it might give us a little bit of a better result rather than hoping that the systemic effects, kick in.
Yeah. So yeah, like, because there is going to be, especially with repeated like injections. Let's maybe kind of talk about like the negative side of that.
Yeah, so we know that after a steroid injection, we see degradation of tissue quality to a certain extent. Collagen's going to break down. Um, so this is where we have to be a bit careful with our loading strategies. So if you get a steroid injection and all of a sudden the pain is gone or you feel, 100 times better, well, if you go right back into the same activities that you got hurt in, you're going to overload those tissues, and you're now the tissue has degraded a little bit. So now you potentially are setting yourself up for a little bit more of an injury. So
Well, yeah,
this is where,
because this is where you, by getting that injection, now you've kind of muted your body's natural like warning sign,
correct.
and now you're just kind of like just yeah, you're taking an, you're you're not treating the issue, you're just masking the pain, and now you're kind of in this zone where you're not feeling the pain, but you could actually, now you're in this, maybe this time where you could actually be doing more harm.
Yeah, so like the example would be recently, Micah Parsons. He was diagnosed with an L4-5 facet joint, basically irritation or inflammation. But the treatment that they supposedly did was an epidural steroid injection. So they're going to the nerve rather than the joint, and they're basically shutting down the entire pain signal in the area, and then they're going to ship him back out and play. And it's like, okay, you blunted the pain signal, but you didn't really address the deeper issue. You're setting him up for potential further injury down the road.
Yeah, and I think that, and also I think that's another issue why the Cowboys let him go. I mean,
Yeah.
that in combination with like it taking up so much of the salary cap. But yeah, I think that was definitely a factor probably into that decision.
Yeah, it's kind of that Moneyball approach where it's like we're doing our risk analysis, and injury history is part of that risk assessment, regardless of the amount of talent or not. So they basically said we're not going to invest in our future in this area. We would rather spend our money elsewhere. So
Yeah. Okay. Yeah. So
blunting the signal isn't always the best option, even though it is an option.
but it's probably, you probably want to go that route before going surgery, because surgery can always happen later. Most people don't seem to, I guess, understand that. People are real quick to jump to surgery. I mean, when you go to see a specialist, it's usually going to be a surgeon, and surgeons see a nail, they're going to use their hammer and they're going to hit it. So, yeah, it's like we kind of, the information that we're getting, because most of us are not truly informed,
Right.
we're going to kind of jump to maybe more extreme measures because of our own ignorance, and that's no fault to you. I mean, we're just not taught growing up in society and culture of like how to be more in tune with our body, and what's important as far as from a movement standpoint. So yeah, just know like surgery is always try to last case scenario. We can always go that route. I mean, yeah, there are some certain times where it needs to be like immediate intervention, but
Yeah. So if we're talking lumbar spine, if there's cauda equina syndrome, which is basically where you're losing bowel and bladder function because of the compromised nerve root, that's typically an immediate surgical intervention. That's a super rare. It's like less than 2% of cases. So we're talking very rare in the grand scheme of things. It is something to be aware of. But getting back to surgery, it's always on the table. But if you don't do your conservative care first, and I mean like really good conservative care, because you can go, like a lot of times, and this is no fault of anyone's, but if you go through the protocol kind of approach and you just kind of get the generalist, oh, like here's low back exercises. Oh, that didn't work. Okay, then you do a steroid injection. Oh, that didn't work. Oh, now you do surgery. It's like, well, did you really give it a try, or did you really just want the surgery and you kind of just mailed it in? You didn't really try in the rehab. You didn't really give it a fair shake. Um, you got the injections because that's what the insurance company told you have to do before you get the surgery. And it's just this compounding. Whereas if you really like, rehab has been shown. So like there's been these trials where they basically do a sham surgery, then they put them through like rehab protocols, and they get better. And then if you look at the long-term history of having, say, a lumbar microdiscectomy versus a really good rehab program, like 2 years later, 5 years later, 10 years later, there's basically no difference. So in that very acute, there might be some differences in the surgery versus the non-surgery groups. But the longer we look kind of out, the more it all kind of washes out in the mix. So it's like, do we really need to have the surgery? Maybe, maybe not. Again, it's all individualized, or each case is individualized. Yeah. But if you're going to a surgeon, their job is surgery, they're going to probably recommend surgery. And I'm not conservative because I'm conservative. I'm conservative because that's the place to start. The goal isn't to start at the most extreme case.
And they're not get, and most are, they're probably not, they're more likely not purposely misleading you. It's just they're trained to like, hey, I became a surgeon, this is how I fix things. So it's like their own bias just kind of is going to promote a certain treatment path.
Right. And that's where...
But surgery, the treatment path, that's, when it comes to surgery, it's for most cases, it's irreversible.
Yeah,
so you might as well exhaust the pathway that you can always, I don't say, you can kind of undo or like take it to the next degree. Yeah, just exhaust the therapeutic standpoint and then really try to delay that I guess, surgical, like that pathway where you can't reverse what you did.
Yeah, you can't go back from surgery. And what, again, people don't realize, surgery is a trauma. So you might have had a trauma, but then you're going under another trauma before the healing even starts. But long story short, if I do an exercise that might aggravate you, we can just give it 2 or 3 days. It can calm back down and we can do a different exercise. You go in for surgery, you have a microdiscectomy, they're cutting pieces out of you, or they go in and they do a fusion. Like, you can't go back. So you have to keep that in mind. The other thing too, this is where MRIs, X-rays, there's a lot of false positives. So just because you have that dispose that we talked about earlier, just because you have something that shows up on the MRI doesn't necessarily mean that it's a surgical intervention. So we might see something on the MRI, but is it a surgical necessity? Not always. So again, this is where the assessment comes into play. This is where having a really good, communication back and forth with your provider, this is where we're going to see the best results. And I want to have a trial of care. So if I'm doing, 6, 7, 8 visits and we're getting nowhere, this is where I'm going to be like, okay, maybe we need some imaging. Maybe we need an outside opinion. Maybe we need a deeper, look at things. So I'm not necessarily quick to pull the trigger on that. I want to give it a fair shake, but at the same time, I know when things should be working. If they're not, that's where we're definitely going to be looking at, diet and those types of things, but also, do we need to jump to a steroid injection a little bit earlier than I typically would, because we really need to put the fire out so that we have an opportunity to do some really good rehab.
Yeah. Um, yeah. Anything we want to kind of add to this?
Well, the thing that we talked about maybe a little bit earlier is like the whole failed back surgery. So this is where maybe just looking at the image, not really doing a great exam, and just jumping into surgery. Um, these are the cases where, or the patient, they kind of skip the triage of conservative to more aggressive, and they go straight to the neurosurgeon or they go straight to the orthopedist, and they basically tell them they want surgery. Because there's people that do that. They're like, the only way that I'm going to be better is if I have the surgery. Um, and so there are surgeons that will do the surgery. They do the surgery and then they realize, oh, well, I still have pain. So upwards of 40-50% of back surgery winds up failing and doesn't give the result that they were looking for, because they really didn't do a thorough kind of assessment whenever they were digging into why the back pain's there in the first place.
Yeah, I mean, because back pain is no joke. I mean, it's debilitating, and just know, yeah, know that if you're going to see an orthopedist and you're going to see a surgeon, I mean, they're trained to kind of go down the course of treatment that they've been trained in, so they're going to be a little biased, but and it's kind of hard because like this is where informed and consent really, I feel like, just almost to me doesn't necessarily get talked about enough or put much emphasis on it, because
Yeah.
yeah, like this there when you go to see a surgeon, they're not probably talking about the 40% success rate, and that, or like maybe they're probably not even telling you what caused that herniation in the first place.
No.
Like just knowing that, and like just having, I guess, more conversations on it and really being informed and knowing that, figuring out what actually caused the issue is just something that just I think needs to become more standard in the industry.
Yeah, this is going to be a bit of a blanket statement, but it's not wrong. So, you go in, every orthopedist or every surgeon, they're going to want their MRI done rather than maybe you had one done previously. Okay, then they have their radiologist read it. And I'm not saying that they're going to tell you that you have something that you don't, even though if you look at MRI studies, there was this interesting study that was done where they gave the same MRI to 10 different radiologists, and there was 10 different reports. They had no consensus. So anyway, then so you go to the orthopedist, they do their MRI, and so they see a problem that quote unquote could be fixed by surgery. So all surgeons, no matter, like, they're all confident. They all know that their surgical intervention can fix what they see on the image. So they tell you, we have a plan. And so the patient sees that as like, oh, well, whenever I went to the PT or I went to the conservative route, they were a little bit more unsure because it depends. There's a lot of factors at play. The body is complex. But whenever they go see the surgeon is like, you have a disc herniation at L5S1. We have a procedure that fixes that. We can schedule you October 4th, and you'll be back playing golf by whatever. Like they just have a way of delivering the information that people feel like, oh, well, let's do it.
Yeah.
Where if I was that confident, that's great. But the problem is there's so much uncertainty around the human body that I could say it, but it's maybe not as true as what I would, be projecting. So I think that the reason why whenever someone goes to a surgeon, they kind of get lulled into, oh, like he was just he knew exactly what was going on. Whereas they go see someone conservative, and it's not that they're not confident, it's just that they accept the uncertainty a little bit more, whereas the surgeon is like, it's this.
Yeah, there's so much nuance when it comes to like injuries and movement in general.
Yeah.
Like, anybody who says they're certain is just, I mean, usually not telling the entire story.
Yeah, and so then this goes back to that top down, bottom up type conversation. So if you go see someone that is like super certain, that's going to give you confidence because, oh, he knows, he has a plan and he has a solution. So that's going to kind of dismantle some of that fear. Whereas if someone's a little, uncertain, you're going to be like, oh, well, he really doesn't know exactly what he's talking about. So it might kind of create a little bit more of that fear around the whole scenario. So I think that that's something to be, considerate of. And then kind of like what you talked about, the informed consent, I think it all needs to be laid out there, all the risks, all the benefits, and really, the patient wants almost us to make the decision for them. It's like, well, what would you do? It's like, well, it's not me. You have to make the decision. You have to live with the decision. And so it's one of those things that if I give you all the facts, all the odds, it's up to you to really come up with the decision. And, it all depends on, if you're a professional athlete, whether they need the surgery or not, sometimes surgery winds up being the option because that allows them to get back on the field maybe in the quickest manner, whereas they don't have 6 months to do the rehab. They need intervention, shortish rehab, get back on the field, rather than 6 months and be a little bit. So it's like, I get it, but at the same time, the risk assessment needs to be kind of laid out. And I think a lot of times the benefits are amplified and the risks are kind of downplayed.
Yeah. All right, let's wrap up bow tie. So
Yep.
I think bottom line is depends on where you're at in your, I guess, your injury cycle.
Mm-hmm.
Bottom line, whoever you're going to see, like, I think it's probably wise you need to figure out what caused the issue that you have, because if you're just treating the pain, you're more, and then you're not treating actually the root cause of it. Whether that's surgery or from a therapy standpoint, you're going to end up kind of defaulting back to your old patterns.
Yep.
So you got to really kind of understand what caused it, have that in mind, so that yes, you can try to treat the root cause if that's not working, and then maybe you're heading down that surgery path. But just jumping in blindly to the most extreme, it's only going to cause, more than likely, worse. It might leave you, more likely, might leave you worse off than where you were down the road.
Yeah, and I think that really just like sometimes we don't really know the true root cause.
Yeah.
But we can kind of come up with like a pretty good idea. And so I think that jumping in, like you said, to something too invasive too early is definitely a problem. But also sometimes, like we've talked about this before, about the accommodation and how your body kind of conforms to the thing you do the most often. And so sometimes we just need to kind of break the pattern of doing something different and then using that as an opportunity to build some new capacities around. But it doesn't mean to completely like avoid trying to kind of dig into some of these things. So I think that you can kind of get lost in, oh, well, like we talked about earlier, like the workaround, like that's good, but making sure that it's comprehensive and not, too short-sighted as far as like just trying to find a quick solution rather than a little bit more of a comprehensive, hey, I want to be able to play golf whenever I'm 65. I want to be able to travel, those types of things. Like, you might not necessarily have this longevity approach, but working on things now will help you down the road. You don't want to be confined to a nursing home or a wheelchair if you don't have to be.
Yeah. Yeah, I think this has been pretty good. So yeah, I think if you found some value to this, please share. If you know somebody who's in low back pain, like who's having some back pain, uh, or you're in back pain, yeah, please share this. We'll also drop a link in the comments. So if you're looking for, like, if you've tried therapy before and you really haven't had great success, and you're looking for maybe somebody who has maybe more of a holistic approach, and maybe trying to dig a little deeper and trying to figure out why you're experiencing that pain, we'll drop a link for Josh over here. So
Sure.
if you're
I would
hearing
be
that,
happy to help, or maybe give you a little bit more of an in-depth explanation of what's going on.
yeah, yeah. All right. Well, thank you everybody for listening, and we'll see you next time.
Yep. See you soon.
All right. Take care.